showing as a slideshow or?
No, sir. The entire PowerPoint the program is showing, not as a. Yeah, now we can see.
Yeah. Good morning and thanks Prasad and Dr. Patra for facilitating this webinar. And greetings to all for this festive season. This happens to be an auspicious month, and today happens to be the Kartika Purnima, which is celebrated in most parts of the country. And the philosophy of the festive season extends all over the world, with the Thanksgiving also coming around the same time, where you enjoy nature, where you enjoy the outdoor activities. So it's unfortunately we are confined to the indoors now, but then this is the best way to spend our time. And it's also nice to rub shoulders with the younger clan, the MBBS students and the budding surgeons. I don't want to make the topic too complicated, but stick to the basics and some fundamentals, and I'll share some pictures and videos and hope they would inspire you all into further reading. So this cannot be a comprehensive kind of information on chronic pancreatitis. But let us remember, first and foremost, and the most important part of chronic pancreatitis is it's a fibroinflammatory disorder of relentless nature. It is not something which comes and goes. It stays with you, which is an important thing to remember, because you cannot have a single treatment for this kind of continuous process. And basically, for that reason, it's a non-operative disease. Operative diseases are basically where you do surgery and be done with it. The treatment is, the patient is cured. Here it is not. We operate only for the complications. And the overall treatment as it stands today is at best palliative. This is the most important part of the concept of chronic pancreatitis we must all remember. I also want to introduce to you to the concept of a patient-centered care. Now, in diseases as this, where you do not have cure, where you have multiple treatments, where the range of severity of the disease is quite variable, you cannot have a cookbook approach. So you have a disease and the treatment is a lateral pancreaticojejunostomy or a pustulosis. It is not like that. It has to be a patient-centered care, and you have to remember what your goal is in treating this patient. So you have to identify the clinical problem in this patient with chronic pancreatitis and direct your treatment towards that, whether it's a medical, endoscopic, or surgical. The diagnosis of, first thing first, the diagnosis of chronic pancreatitis is both clinical and imaging. The classical chronic abdominal pain in the center of the abdomen, generally after a meal or an alcoholic binge, radiates to the back and is relieved by sitting up or assuming an erect posture. It relapses, and you can have symptoms of, apart from pain, the symptoms of pancreatic exocrine insufficiency and endocrine insufficiency, and symptoms of complications, the ductal ruptures, the pressure on surrounding structures, etc. And occasionally, it is asymptomatic. You do see many patients who on a routine ultrasound come with a grossly dilated pancreatic duct and stones, and in spite of your probing, you don't find any history. That's kind of a dilemma where you do not know what to do. Imaging, of course, is the diagnostic, where either ultrasound, CT, or MR would show you the atrophy of pancreas, ductal dilatation and strictures, or calcifications in both parenchyma and the ducts. Etiologic mechanisms, I just want to show you the slide for you to go into the depth of these and find out why a chronic pancreatitis occurs and what is the pathogenesis predominantly, so that you can direct your treatment to that aspect of the pathogenesis which is predominant in this patient. which could be either a ductal obstruction, a large duct, or what you call, you have a fibrosis and the strictures, or there are triggering factors which need to be controlled before you offer any definitive treatment. This is the acronym which you would remember for remembering the pathogenesis. SAFE hypothesis, I particularly wanted to tell you because this is the pathogenesis which is most relevant for a chronic pancreatitis. Now you know that generally speaking, in many of the patients, it starts as a first episode of severe acute pancreatitis. And then there are a lot of inciting factors which would continue to affect the pancreas, leading on to the periesonar fibrosis and the strictures and ultimately the chronic pancreatitis. If you catch the patient at this stage, say after the first episode and before the multiple attacks of mild pancreatitis resulting in a chronic pancreatitis later, you can still heal, you can still have a normal healing of pancreas. This is of course still on the table, still not in a clinical situation, but this is what we are going to achieve ultimately. The complications you should know, because it's predominantly the complications that you treat, which are because of ductal rupture, you can have a pseudocyst, which can be either in the pancreas itself or in the peripancreatic area. You can have obstruction because of the fibrosis extending onto the, not only just the duct, but the peripancreatic structures leading to biliary obstruction, portal hypertension, or ruptures leading to fistulas, ascites, and a pseudocyst, and ultimately a pancreatic neoplasm. In Indian circumstances, we claim that it occurs to the extent of 8 to 10%. 4% is outside India. And what is the goal of your surgery? It's important to remember what your ultimate aim is, predominantly to alleviate the pain and palliate all the complications. Mind you, we are not using the word cure anywhere here. And the procedure you are adopting, either endoscopic, percutaneous, or surgical, should be a simple procedure, and it should avoid further damage, further exocrine and endocrine insufficiency. And as we claim in surgery, well, there is bound to be a surgical bias in these presentations, because as we see, all the presenters are surgeons, and probably all the participants, the delegates, are also surgery oriented. But then if MBBS students are present here, they should also remember that surgery is just one option for a chronic pancreatitis. And now we claim that early surgery or surgery in early chronic pancreatitis is also helpful. And we also claim that surgery may decrease the rate of irreversible changes. So this is the ultimate algorithm which you would remember for a chronic pancreatitis, where the pain is the predominant symptom. Your important step is to exclude non-pancreatic pain, because clinically it is impossible to diagnose a chronic pancreatitis. And once you diagnose a chronic pancreatitis, you have a conservative treatment for 10 weeks, which involves analgesia, avoidance of the triggering factors, dietary management, micronutrients, and enzyme treatments. And if it is effective, you would just continue these. If the treatment is not effective, next step is to know, is it a large duct disease or is it a small duct disease? Small duct diseases are difficult to manage. It's ideally left for the medical management, but if medical management fails, you still have the surgical options. When it is a large duct disease and pain is the predominant feature, next step is to know, is there a mass associated or there is no mass? If there is no mass and it's a large duct disease and there is pain, that is an ideal situation for a surgeon to offer a surgical drainage of the ductal system. Whereas there is a mass, you go into a different algorithm, which would go a little more into the detail later. See whether it is a cystic mass or a solid mass, which means there is a chronic pseudocyst associated with chronic pancreatitis, or there is a solid either inflammatory mass or a malignant mass associated with chronic pancreatitis. requires a detailed investigation. If it's a pseudocyst, part of it is, Sachin is covered, is that endoscopic drainage predominantly, because surgery, yes, surgery is also useful when you can combine a pseudocyst treatment with the ductal treatment. It's possible when you have a pseudocyst, a communicating pseudocyst with a duct and in the pancreas itself. Whereas when it is outside the pancreas, which can also happen in certain cases of chronic pancreatitis, first you treat them with endoscopically and then assess the pain. Is the pain because of the pseudocyst or because of the parenchymal problem? If it is because of the pseudocyst, you have a way of assessing the pain. Pain is relieved and you can still manage conservatively. On the other hand, if your pseudocyst is drained endoscopically and the pain continues, then you have no option. I don't intend to go into the details of anatomy, which are very well covered by Dr. Patra, but I'll just emphasize on the areas of functional importance for us, for surgeon. Now the duct, as has been mentioned already, this is the main duct, and this is the main duct which takes a dip here and goes deep, which is very important to realize that the main duct here is as much as 2.5 centimeters deep from the surface, which is an important thing to realize. You have an accessory duct here. So what are the areas where you want to concentrate on? This area, one, because of the direction the duct takes into the depth of the pancreas. And this is the portion which you would miss when you're offering surgery, because it stops here. And after that, when you probe the duct, it is a little difficult. It just doesn't go in. So you think it is the end of the problem and leave behind all this. This area is also important because of the close proximity of the vascular structures here. The SMV, the portal vein and SMV can be very close to the posterior surface of the pancreas here, even the anterior surface of the pancreas, if the pancreas is atrophic. If the duct is not very clear here, it's quite easy to injure the SMV and the pancreas and the portal vein at this stage. So it's important to identify these vascular structures before you tackle this area. So this is the importance of the anatomy. And then the other area is, of course, the tail, where you would miss the stones here, you would miss the fibrous stricture here, and then that is the cause for persistent pain after you offer surgery. The vascular anatomy, again, I don't want to go into the details, but it's important to remember the arterial and the venous anatomy here, the detailed anatomy, because these are the structures which would come into your way, and they're not very clear in the chronic pancreatic fibrosis, where this whole thing may appear as a single mass, and these structures are hidden here. So unless you have an orientation of the vessels where exactly you would find these, and if you can take care of them before you do a head coring, which is a very important step in your surgery, you can have significant bleeds. So that is the importance of the venous and the arterial arcades around the head of pancreas. So the other important structure which you should know is the gastrocolic trunk, which as you lower the transverse colon from the pancreas, and this is the area where it is adherent, and you give a little extra traction and the gastrocolic trunk tears, and then you can have a significant amount of bleed directly from the portal vein. I hope the video works. Is it showing? The video is showing?
Yes, sir, it is coming.
Okay. See, what I wanted to show you is how things are so unclear here. And if you know the orientation of the vessels, you can directly go right up to the vessels. And you see the areas of anatomical adherence. See the natural peritoneal attachments, how they would separate in spite of being so unclear to start with. And you go straight to the vessel and you preserve the vessel here, divide the gastrocolic trunk, and then you have the entire body of pancreas and head of pancreas is in front of you, and you are safe. Sorry. So this is the anatomy here. The anterior superior pancreaticoduodenal vein, the right gastroepiploic vein, and one of the colic veins, either right colic, accessory colic, and rarely even middle colic vein. There is a lot of anomaly here, but then the direction of the vessels should remain the same. And it's important to get to this area of the gastrocolic trunk and then divide this. You can either go right up to here and divide, or if it's not possible, go one by one, go to these structures, ligate them, and then get to this area. The area is important because, see, the area is so small. It's so small to take a ligature around. So it's also important to know what is the mechanism of pain in chronic pancreatitis, because that is the predominant symptom which you are controlling in the management. It is not just the interstitial and intraductal hypertension, which of course is the predominant cause of pain. The ductal hypertension because the strictures and the stone load, and the interstitial hypertension because of something like a compartment syndrome in the pancreas, which is responsible for this. And that is the pathogenic mechanism which you are addressing when you are doing a head coring or a head resection in the surgery. And then, of course, the pseudocyst also causing pain through the nerve connections. And it's also important to remember the central neuropathy and the neuroplasticity, which is responsible for, even after you block this area, you still have the pain. After celiac block, after dividing all these, sometimes you still have the pain. And after relieving the intraductal and interstitial hypertension. And this is an important pathogenic mechanism which also requires in recurrent pain after your management. So the classical operative approaches can be classified into three: the drainage types, the resections, or a hybrid of them, and of course denervation. The indications for intervention, the most common indications are pain, pain, and pain, and then complications. Pain and complications are the indications. The mere presence of chronic pancreatitis, mere stone load is not an indication for an operative intervention. This you must remember. Uncommon indications: sinistral portal hypertension, left-sided portal hypertension, where you can have a cure of this part through a splenectomy. And if there is an associated a pseudocyst or a focal pancreatitis in the tail, a distal pancreatitis. Bleeding, complicating the pseudocyst and other inflammatory head can also be the indications for a surgery. The ductal drainage, the classical lateral pancreaticojejunostomy, along with a coring out technique of Frey, and in small duct disease, the ESIC's procedure, where you have an extended duct drainage or a V-shaped excision of the duct and drain, or a pseudocystojejunostomy, and organ preserving resections, Whipple sometimes, spleen preserving left resections, or even middle resections if it's the focal. This is just an easy way to decide on the type of surgery. You have a grossly dilated duct, pustuous. Head mass, heavy stone load. In addition to pustuous, you also do a head coring. Focal inflammatory mass in the head alone, few stones, small duct, and no exocrine endocrine dysfunction, Frays or Whipple. A small duct disease, either head resection or ESIC's. So the type of ductal anatomy you have, and the mass, the problem in the pancreas, and the amount of suspicion of malignancy, you decide on the type of surgery. Just a little bit into the classical imaging pictures. These are all the classical pictures of, say, you have the advantage of having various views and then decide on the ductal anatomy, the stone load, the mass, and I will just show a few brief steps of the surgery itself. The first step in majority of the procedures here, whether it's a Whipple or a chronic pancreatitis or a D2 dissection, you do the mobilization with hepatic flexure and cock rise It's important. The important thing to know is not to go too deep and get into the perinephric fat. Geratus fascia in Enovis would go there, you know, because this whole thing appears like a mass. It's important to know the peritoneal attachments here and get into just the divide and mobilize the hepatic flexure, not necessary to mobilize the entire transverse colon, but identify the paraduodenal area and cauterize. So this is a very important step the budding surgeons should practice, identifying the anatomical planes here, the peritoneal planes, without too much of a traction. See, it's not that difficult to get into behind the duodenum by cut and ligate and ligate and tie. It's not that. How you identify the tissue planes and get into the correct anatomical planes and get into the retroduodenal area is important thing which you should practice. Okay. Now, after that, get to that. See, it's important to mobilize not just the behind the pancreas, but the upper and the lower borders of pancreas. You should have the pancreas in your hand to feel for the duct. You feel it as a kind of a cystic area, a cleft here, or sometimes you can just feel the stones. That's the way you identify the duct. And first thing, identify that area. See, you feel that, and then you know where the duct is. If it is not possible, get to the border, both the borders, lift the pancreas, and then you can feel the duct. Or sound the stone with the needle itself, and then you get into the duct. And once you have this clear rice water-like pancreatic juice, keep the needle in place and open the duct. And that's the way you keep opening the duct. It's important to have two things when you are opening the duct. A bipolar cautery with you and a 40 or 50 fine Prolene stitches. They're the ones which would take care of the hemostasis here. And then my way is, at the moment you identify the duct, I put everting stitches on the duct itself, which would help you in both traction, to show the duct and the branches clearly to you, and also take care of the hemostasis, just like you do for when you neurosurgeons like they everting the scalp. That helps in controlling the bleed from the duct. And as you open the duct, you clear the duct of all the stones and keep feeling for the branches too, and feel for the see as the stone, as you open the duct, the stones come out, and then remove all the stones. Concentrate on the areas which are shown to start with. We'll come to that. Yes. Yeah, this is the important how head coring is done. Say you have the duct in this direction and then it dips down, and this is the area which we have realized in the past decade that it's important to have a patient with no recurrent pain after your surgical procedure. And this is the area where you have to take care of the portal vein. Before that, you must identify where the portal superior mesenteric axis is, avoid that, and identify the segment of pancreas between the accessory duct and the main duct. You may not even be able to cannulate the duct here. If you have the duct, main duct in the body and up to the neck, you can identify this area and do a slicing, or you identify the stones and get onto the stones, open there and get retrograde into the main duct. That's the way you open the branches. This is the way you slice the head, the inflamed head. And as I said, the important thing to have is a spray type of coagulation here, or a bipolar, or a 40 or 50 delicate suturing material. So this is how you do the head coring. And identify the branches also. See, as you're not satisfied with just the main duct, you identify the branches here and get all the stones, you must be able to feel the posterior surface of the pancreas between your two hands. That is the amount of head coring that is required in all the cases where it is relevant, which means you have an inflammatory head mass or the stone load. Most of the stones you will be able to feel in the head by lateral palpation from with your 3 or 4 fingers behind the duodenum and the thumb in front. Okay, and then once you open the duct, the anastomosis is a simple matter. I always put a fixation post sutures here so that you have a jejunum which is not, moving, and as you keep suturing, this keeps getting extended, and you find a lot of redundant jejunum. Although initially you measured equal, so this is the way to avoid that by fixing the exact area of jejunum you want to anastomose by putting a few posterior stitches, and once you are used to it, you can even put a continuous suture here, and then do a duct to, well, mucosa is not always necessary, but wherever it is possible, you also include the duct here and do a complete duct to mucosa anastomosis. Well, see, I just wanted to show you this picture. This is not a grossly dilated duct as you might mistake. It is not, although there are some stones. This is just a fatty replacement of the entire pancreas. This patient was not even symptomatic. Fortunately, did not even have insufficient this thing, but you should not mistake it for a grossly dilated duct. Now, I also want to show you, see how sometimes, say with over-enthusiastic endoscopic colleagues, this patient was stented 6 times and resulted in multiple strictures. All the strictures were because of repeated stenting and presented with severe pain, and they can be nightmares for you, and sometimes when you are forced to operate on that. Endoscopic treatment still has a role. It has a role when there is an obstruction or a stone in the head or very close to the ampulla, and then there is dilatation. It's easy, simple thing to either break the stone, remove the stone, and stent the thing. And then a short-term treatment of common bile duct obstruction. When it's accompanying, you can have a bile duct stenting, and it's also effective for non-surgical management of ductal leaks and disruptions, particularly if they are in the proximal, in the head area, and you have a ductal disruption and pseudocyst or a pancreatic ascites, endoscopic treatment, and of course ES guided celiac block. Early chronic pancreatitis and surgery. This is a recent paper which has clearly demonstrated the advantage of surgery in a chronic pancreatitis in the early phase itself. Of course, this still requires some more evidence. Now, the pseudocysts in chronic pancreatitis are partly dealt with. When it's a huge pseudocyst like this, you would still go to endoscopic treatment first, and then depending on the persistence of symptoms, you would opt for surgery. If it is, on the other hand, in the tail of the pancreas and you have these stones here, you can combine surgery itself. And you have a cystic area, say this is a very difficult situation where it is in the head and is causing bile duct obstruction, and it's impossible sometimes to, of course, thanks to EUS and ES guided investigations, you have some guidance now, but to rule out a cystic neoplasm here from a chronic pancreatitis is sometimes very difficult, particularly when you have a chronic pancreatitis. In addition, see, you do have strictures here in the duct and a gross cystic area which is causing bile duct obstruction, and you did they had to do Whipples for that. You can have pancreatic pleural effusion, pleural pseudocyst extending into this one also. So complicated chronic pancreatitis and pseudocyst occurs in 1/3. Mostly it is intrapancreatic. That's how you differentiate it from post-inflammatory or post-acute pancreatitis pseudocyst, which are predominantly extrapancreatic. It is important to confirm ductal communication to avoid any percutaneous drainages and avoiding pancreatic fistulas, and to prognosticate the patient and offer, if possible, and feasible an endoscopic treatment. Complications of pseudocysts, they can get, like any other pseudocysts, they can get infected, they can bleed, they can cause obstructions, they can cause rupture. Biliary obstruction is another area which is an important complication of chronic pancreatitis. Say you have double duct obstruction causing both pancreatic duct and biliary obstruction. And these are the various types of biliary obstructions you can have in chronic pancreatitis, which are also typed. They are important for offering either endoscopic or surgical management and decide on which to offer. When you have a stricture so high up, sometimes it's difficult to give a endoscopic treatment, and this kind of strictures may require even a confirmation of malignancy, because chronic pancreatitis, the stricture is here and here, it's more of a malignant origin, and this is one area where so the biliary obstruction in pancreas, chronic pancreatitis, how do you manage? You look for pain, persistent jaundice, mass, and a pancreatic ductal dilation. These are the things which you would look for, and then decide, is the pain predominant? If it is not, and is there a persistent jaundice, or is there no jaundice? If there is jaundice and there is no pain, biliary stent. Yeah, or your surgical bypass if the jaundice is persistent or biliary stent is not effective, and in the form of either a choledochoduodenostomy or a choledochojejunectomy. And sometimes, if it is only an extrinsic obstruction in the head of pancreas because inflammatory mass, simple phrase or pancreatitis can relieve the obstruction in the bile duct itself. So if there is no jaundice and no pain, still conservative management in spite of liver function tests being altered. On the other hand, if the pain is predominant, again, see whether the jaundice is present or it's only a transient jaundice. If it's a transient jaundice, again, you have the option of conservative management. And if the PD is also dilated, either a phrase with hepatocoagulopathy. Duodenal obstruction, when you have with a chronic pancreatitis, you must seriously think, is there duodenal obstruction because of malignancy? Because chronic pancreatitis causing a duodenal obstruction alone, although it can occur, it is rather unusual and rare. Portal hypertension is another dangerous area, difficult area with chronic pancreatitis, and it can be either due to extrinsic compression or because of the thrombosis of the splenic mesenteric-portal axis. And it's a splenic vein thrombosis. Your algorithm is just, when you have a portal hypertension, the first thing to decide, like any other extrahepatic portal hypertension, is the patient a bleeder or a non-bleeder? If it's a non-bleeder, and are there any pancreatic symptoms? If there are no pancreatic symptoms, and there is only a portal hypertension and without any other symptoms and a non-bleeder, you just need to follow up and then say medical management. On the other hand, you have pancreatic symptoms, the appropriate pancreatic procedure, and for treating the portal hypertension also, you may need to add a procedure. On the other hand, it's a bleeder. First management, of course, is endoscopic control of the bleed. And if it is unsuccessful, depending on whether there are pancreatic symptoms or no pancreatic symptoms, and the type of ductal involvement, you either decide on splenectomy and distal pancreatectomy, or a procedure for portal hypertension, which is either a shunt along with a pancreatic procedure, either together or in stage. Visceral aneurysms are another complication of complicated chronic pancreatitis. And thanks to our angiographic and percutaneous colleagues, now we have many of these, they are able to manage them with angiographic means, embolize them, and then give us an option of managing the chronic pancreatitis alone. Pancreatic ascites is a difficult problem, and it's either due to a leak from the pancreatic duct or a pseudocyst. And initial management, of course, is conservative. A lot of them, by a simple peritoneal drainage, they get and give time with octreotide, and if you can identify the ductal disruption by endoscopic stenting, can be managed. but in a rare instance, we may have to do surgery. Head mass, I hope it is not too complicated for the audience. I don't want to go into too much details, but it's a difficult problem to be dealt with only by people who are used to this kind of problems. Chronic pancreatitis with a mass in the head of pancreas, which is which can give a lot of diagnostic problems, and this is the algorithm which should be followed. A discrete mass without symptoms, as a matter of principle, biopsy, yes, you should attempt with endoscopic ultrasound guidance, but if biopsy is positive and result, if biopsy is negative, close is the standard advice. But then there is a caveat in this. Benign result by itself never excludes malignancy, and if an experienced surgeon cannot exclude malignancy on table, resection is a safer option than simple close, because these are the situations where you can offer sometimes curative option. So in spite of all these advances, fortunately or unfortunately, the advances are not that shattering. They're not earth-breaking advances in the past 1 or 2 decades. We only know what we are doing, and we know how to do how to select a patient and how to do a safe give a safe surgical option to these people, which has led to, say, even a recent paper like this, a chronicle of confusion and despair in chronic pancreatitis. But it's not as bad as the paper suggests. It's like many other situations where you do not have a curative option. You have to live with it, but then you can live comfortably with identification of the patient's problems, identifying the clinical problem in a patient, and identifying your goals. So this is my take-home message. Never treat the chronic pancreatitis. Treat the patient with chronic pancreatitis. And this is a repeat of the algorithm which I've given. And I think that is the end of my, well, call it brief or extensive talk on chronic pancreatitis. I hope it is not too complicated. I hope it's not left you with many more questions than what you already know. Doubt your knowledge. But then, say, these are the basic principles you must remember when you are dealing with chronic pancreatitis. I think I'll stop here. Thank you for the opportunity given. Thanks, Dr. Prasad and Dr. Patra.
Yeah, thank you very much, sir. That's really extensive, and as always, you are an excellent teacher, to say the least. And if there are any questions, I don't see any questions in the chat. If there are any questions, the speakers, the delegates can unmute themselves and ask. We will take 2 or 3 questions and then close the webinar. Anybody, just unmute yourself and ask the question.
I'm not able to.